Good morning, sir, and everyone. Today we will start the AI subject in context in healthcare. So many of you maybe already understand and worked with AI algorithms and all, but this course is for everyone, even who don't have any idea of what machine learning is or deep learning is. For the beginning at zero level, they can understand. So this has been planned in such a way. So who know much better than the others, please bear with me and let me start this topic. So this is my overview of today, the basic concepts of AI in healthcare. So why this course matters? Healthcare today is experiencing a fundamental transformation driven by explosion of clinical data. The data comes from record, imaging, bedside monitoring, genomics, lot of variety of modality. So the need for assessing this complex and high dimensional data and have a effectively accurate, reliable tool is necessary for today's assessment. And this course is not for coding. This is about helping clinicians to understand, interpret, and safely use AI in practice. The artificial intelligence has emerged as a tool that can assist clinicians to handling this complex data to identify the pattern, predicting outcome, and supporting decision making. So this is a supportive tool, and decision is from clinician only. In this regard, Hippocrates' observation tells to help or at least to do not harm. And it is more important to know what sort of person has a disease than to know what sort of disease a person has. That means it is going from evidence-based medicine to the personalized medicine. And it emphasizes patient over disease. And physicians are the convener of the whole ecosystem for clinical and moral integrity. There are a lot of area in healthcare, almost every area AI has entered, and there are ongoing applications that has been helping in day-to-day clinical process. So starting from the basic statistics that we already know, the basic stats answer few questions. That is building causal evidence. Does this intervention genuinely lead improved clinical outcome? Answer is coming from here. Effect size and generalizability question. What is the magnitude of benefit? And is it applicable to my patient population in current scenario? Then diagnostic as probability. Give the test result. Given the test result, what is the probability that my patient has the disease? And uncertainty and decision making. So what sort of confidence level is there in the accuracy level? And the presence of unavoidable uncertainty, what is the accuracy interval and how it will be reliable? So all these questions are answered by lot of statistical methods that we already well know. Descriptive statistics to study design, sample size, hypothesis testing, then estimation of confidence interval, regression analysis, survival analysis, diagnostic test evaluation, clinical trial analysis, meta-analysis, epidemiologic measures, bias and confounding data quality. So there are a lot of methods for clinical data analysis and decision making in population level or in cross-sectional data. So in this whole horizon, why AI? So AI adds something more to it, where it does not assume a predefined model in the data. Rather, it finds a pattern or model in the data. What is the data that it finds within itself? And when traditional statistics is very simple and interpretable, at the same time AI is complex and difficult to interpret as well, because it is handling lot of data, while statistic is doing some population, some limited variable analysis, AI can handle diverse kind of data that we will see. So there is some overlap in between machine learning and statistics, but there are more beyond the statistics. We can tell machine learning as an advanced statistics method, but beyond that, there are a lot more. So when we compare it, the traditional statistics is model driven. It predefined the data structure, understood maybe normalized or non-normalized distribution, but AI does not follow that. Then traditional statistics is a few variable. It uses few variable linear disk model and static probability, while in deep AI it is personalized kind of analysis and prediction of a probability for any kind of decision. And it statistics gives a confidence interval, and AI model gives a risk benefit analysis and confidence interval for that personalized prediction probability. Of course, statistics is simple, interpretable, and it requires less computing facility. AI is very complex, need high performance unit, and many software tools. So now come to some common clinical interpretation and terminologies to understand the AI domain. So association is not prediction, not causation. Association is when variable move together. Prediction is forecasting some outcome, and causation is when X change, Y also change. Means X is the cause of Y. So biomarker may correlate with disease, that is correlation, but only causal evidence guide treatment outcomes. Next is bias versus variance trade-off. Bias means data is aligned towards some type, not all type of variety is covered. But variance means lot of different diversity among the data sample that may have noise also. So this bias and variance that has to be balanced to have a more generalized, reliable outcome. Simpler model are safer, stable, and more interpretable. And more data does not equate to the better model. Quality matters, quantity not. So some common terminologies when we do our analysis with clinical data, the performance and trials terminologies, the search and find metrics means when we are getting the result in terms of accuracy, confidence interval, sensitivity, specificity. So what we see in biostatistics, the confidence interval is now prediction intervals in AIML. Sensitivity is recall, means ruling in the detecting the true positives. Specificity is detecting the true negatives. And type 1, type 2 error in stats is now false positive or negative rates. So in clinical application, when we will talk AIML, we will understand in this terminology, in this meaning. So in biostats, when logic and interpretation is the why matrix, why we are getting the result, when this question comes, because in AIML, it is a kind of black box, the explainability is very limited, interpretability is limited. So understanding the method, there is some way. How many is the data set? When in stats we have sample size, here it is training size. The effect size in stats is now feature weighting. How much feature we are giving to have our objective, the outcome. So this is the strength of the features. Then p-value tells us the significance of a parameter, right? In our analysis, here SHAP is a feature prioritizing technique that tells about which method is pushing, which feature is pushing our analysis towards the positive or negative outcome. And then the area under the curve, the conventional understanding is equal in AIML. And next is the trust and deployment, the real world. When we are talking about deployment or applying the model in regular day-to-day basis, then we need to understand few things. In biostat, what is calibration? It is the calibration curve, mean the outcome, exact outcome, and the predicted probability, how both are aligned together. It calibration curve tells about it. It gives the reliability factor of the AIML model. Then generalizability. It means the model, what is developed in using some amount of data set, whether it is applicable to another new data set also in the same manner. So this is the generalizability. So out of distribution means the new patient population has to be applied for the model. That will give the generalizability aspects. Then bias is the alignment towards some specific cohort or type or geography. So that is the biased model. It will not be generalized. Then the model drift is the expiration date. Means old model may not be fit to a current scenario if the clinical assessment protocol has been changed or the data acquisition or data capturing machine protocol has changed. So it needs to be repeatedly monitored and upgraded. So these are common terminologies. And now come to some simple mental model. When we do different tasks in every day in hospital, we do diagnostic, risk stratify, recognize patterns, summarize records, plan next steps. So these are common actions that is taken in hospital scenario. So diagnosis is the prediction in AIML. What is this? What is likely to happen? This stratification is the discovery. Are the hidden pattern or subtype in data? And recognizing pattern is the interpretation. Can the system read image or text? Summarize record is generation. Can it draft or summarize a content? Then plan next step means automation of some actions that will help to organize multiple steps in the workflow. So all these steps that covers day-to-day critical activity in hospital that falls in different sectors of AI algorithms. So prediction, discovery, interpretation, generation, and action support. All these are that can be mapped to some AI algorithm. Prediction is supervised learning. Discovery is risk stratification is prediction or risk probability that may be supervised or semi-supervised learning. Interpretation is unsupervised learning, finding some pattern in the data. Generation is generative AI, generation of some new data, text or image. And action support means automation of workflow, that is the agentic AI. So this is the whole landscape. It will cover the whole landscape when we think about a hospital day-to-day activity. Now, start with the basics. What is AI? AI is a system that mimics human cognitive function. This is a problem-solving pattern recognition tool. But this term, human cognitive function, mapping that is not very easy. So when we do traditional software, it is kind of, if symptom is A, then treat B. Otherwise, do something else. So it is a if-else kind of conditional rule-based method when the traditional software works. But artificial intelligence have some more analytics to understand the hidden pattern in the data that we analyze in our brain and interpret and do some action for it. So that understanding comes from really high level of abstraction of data that AI performs. So it can be, I will think about a junior resident who is incredibly fast, slightly rigid, and it has memorized millions of cases, that is data, and can spot pattern instantly. But it lacks common sense, intuition, and holistic patient understanding. So who are junior resident? I don't think here is anyone. All are senior resident and in advanced stage. So this is kind of a very naive student who is very enthusiastic, gather a lot of data, but don't have the experience and the insight. AI is like that. So it can produce many information for you, but only the decision, the insight is there with the clinician. So we should use AI with caution. So in AI hierarchy, already I think everyone know this hierarchy where machine learning is subset of AI, deep learning is subset of machine learning with some more functionality, and generative AI is subset of deep learning with some additional functionality. So to very low level understanding, machine learning takes structural data that is tabular form in Excel sheet or spreadsheet. Sometimes it can handle unstructured input also, but some feature engineering need to be done to extract that tabular kind of data from the unstructured data, because machine learning can only handle tabular structural data, and it gives a structured output. Deep learning can handle both structured and unstructured data. Unstructured data means any kind of data that is not in tabular form. Image, signal, text, it can be video, it can be anything. And generative AI handle both type of data and it can give both type of outputs. So in last class from Manoj sir, we have learned all these basics, but still I am repeating to accomplish for completion. So when we go from left to right, like basic statistics, logistic regression towards the generative AI, the more flexibility of data handling increase, as well as complexity and also increase. And when we go from right to left, it is more interpretable and easier. So we have to choose when to use what. This is whole landscape of AI. Under machine learning, there is supervised learning, unsupervised learning. Under supervised learning, there is classification and regression. Classification is having yes or no kind of output at the end. Regression means having a value, predicting a value at the end. Unsupervised learning has many types of algorithm for clustering, dimensional reduction, and anomaly detection. And there are different other variant also: semi-supervised learning, self-supervised learning, transfer learning, and reinforcement learning. All these are mix and matches of supervised and unsupervised learning. And then comes the deep learning umbrella. It has the computer vision, that is CNN, convolutional neural network is one main component, and natural language processing algorithm, that is another main component. Neural network is the inherently is everywhere in deep learning algorithms. And then comes the generative AI and agentic AI, that is very new emerging techniques. So understanding these categories will help clinician to interpret the model, the results, choose suitable use cases, and ask better question about the safety and reliability and values. So now we will see the basic concept of the I'm coming to the every algorithm with example. So now for each and every algorithm, we will see how it works, the basic concept, understanding, and with the example, we will understand how it can be applicable in clinical scenario. So in supervised learning, the data have input parameters, the different type of blood reports, demographic or etiology parameter maybe, and the label. It may be here, it is rectangle, circle, triangle, different type of shapes. In clinical scenario, it may be a outcome like mortality or a responder or non-responder, or some tumor, benign or malignant kind of outcome. So it will go to machine will learn how to map the input parameter to the outcome labels, And then it can see the new based data and it can be classified or prediction can be given accordingly, according to the levels. So the limitation is it need levels, and labeling is expensive, of course, and it needs lot of data most of the time. But often it is the accuracy level is very high, understandability, explainability is very good, and it is very well suited for classification and risk prediction model that is very commonly used and well understood methodology. So this is the most commonly used method in healthcare scenario and maybe in all sectors. The supervised learning for predicting a probability for a outcome class. One example is to classify liver cirrhosis patients as Child-Pugh ABC from CT image and lab values. So we can have patients with CT lab result, hepatologist confirmed Child-Pugh scores, and we can give all the data with feature engineering from CT data, of course, to machine learning model. And then the output for new patient can come as automatic classification with confidence score. Automatic classification to any of this category of Child-Pugh A, B, C with a confidence score of the probability. The outcome will be like a probability value from 0 to 1. If it is above 0.5, it is positive. If it is less than 0.5, then it is negative for a 2-class classification. If it is 3-class classification, then it will give a probability value for these 3 classes. Which one class have the higher probability, the end result will go to that group. So when it is multiple classification, then the probability is also, total probability will be 0 to 1. So it will be distributed in 0 to 1 values. So in almost all the probability will sum up for one value. So the higher probability for a class will be ultimate end result. So it is helpful for rapid trials. In unsupervised learning, we don't have the level. Only we have lot of clinical data or any kind of input data, and machine learns the hidden pattern. Means what is the inside the data, what is pattern, if there is any pattern or not. The pattern may be in different way. So there are different type of clustering algorithm. In next class, when we will have machine learning methods, we will see the type of patterns. So for now, let's understand it will collect similar type of samples together to have a cluster of it. So how the similarity is calculated and how it is clustered, the pattern of clustering is it differs from algorithm to algorithm. So major understanding is it finds a similarity factor in the samples depending upon the input parameters. So most of the time it is used for identifying phenotypes in our data. So finding clinically meaningfully some group of patients that is similar to each other. So, for example, when we are analyzing MESCENT, it is not a single digit. There may be some internal subtypes, and the different prognosis risk may be associated for different subtypes. So we don't know what is the prognosis outcome and what is the different subtypes. So lot of national patient data, demographic, metabolics, genomics, imaging features that can be fed to a unsupervised learning algorithm. The algorithm cluster patients based on data similarity, and it is hypothetically, I have written this, it may not be true, it can identify 3 clusters, cluster A, B, C with inflammation dominant disease, genetically predisposed disease, and metabolically driven disease. So this type of phenotyping, the characterizing of subtypes within a cohort can be identified using this type of unsupervised clustering method. Now come to semi-supervised learning. it is mixture of supervised and unsupervised learning. When we have lot of data, but we cannot afford labeling the data, all the data, because it takes time and it takes lot of expert time that is useful for more important work, clinical work. So for that type of scenario, what we do a small set of data set with level, train the machine learning model in supervised way. Then we apply this model with the unlabeled data set and have the prediction for it. With the high confidence prediction, the data set from this second phase of prediction, that is feed into the model again with the initial small level data sets. And then the model is updated with the level and the predicted level data set. So this is semi-supervised learning. It is useful when the labeling burden is very high and it can handle in a very cost effective way to handle the data and analysis. But it may be erroneous also because it is mixing the unsupervised learning also. So what I have explained, that is summarized here only. The 100 ACC study with confirmed labeled and 1,000 surveillance ultrasound without any label. So we can predict the surveillance ultrasound with the trained model with some small sample set, and then we can retain it, and it can be used in community basis where the expert radiologist is very less and we cannot afford to have label data by expert. Then self-supervised learning is method where the model learn itself the pattern in the data. It do not have the label. It identify the internal pattern in the data. How it is done? It handles the data with some masking of some portion of the data, maybe text or maybe image. Some part is masked, and model try to predict the masked portion from the existing active portion, and slowly it learns the masked portion and it can generate that part. So it needs lot of huge number of data set and lot of processing power. It is not the day-to-day life activity kind of thing. So most of the time, the ImageNet or DenseNet, the GoogleNet, all these type of large deep learning models are these self-supervised kind of models that handles billions of data, and it can identify the internal pattern in the data set. So there is lot of input data with different type of variety. The model here, this is convolution neural network block diagram. We will come to this in future, next class, when we will learn the deep learning methods. So just think about the deep learning model, understand the internal variety structural pattern in the images, and it learns the pattern. Then with some specific type of data, it can handle it, identify the pattern, and it can recognize what is the actual means, what is the images. So for example, it can handle lot of data set. It use one common use is data augmentation. It can use a image, and then it can generate lot of different image by rotating or shuffling it or slightly making some small changes into it. So this type of use is here in self-supervised learning. And then the transfer learning, it is also very useful when we have some specialized kind of action to do. Here also, the convolutional layer, that CNN learns the data set for different level of features. In convolutional neural network, it learns high level means micro and macro level data, means higher level and more granular level spatial features is captured by the convolutional neural network, and then it train neural network dense model to identify some outcome. It may be a prediction or any probability prediction. So in this workflow, if we here freeze the feature extraction step, how it has read the feature, that is general. That whatever the input image is, this convolutional layer means the feature extraction layer will do in same way. So at this point where the scissor is pointing out in the image, here we can freeze it, and it can be used for any type of clinical data set that is already available. Model can be used for any kind of clinical image like pathological slide image or any CT or MRI image to have this feature set, and then we can train our model for our objective. So this is called transfer learning. What already learned by some existing model, that learning we will transfer in our kind of data set for our objective. So that is called transfer learning. So in community hospital, for example, in community hospital, if we deploy AI model, the lesion detects, but detection model can have very limited local data set. For that type of situation, kind of telemedicine or remote access centers, here this type of model works very well. It handles the already trained large data used model, and it can locally tune the model with their own data set and having the outcome. Next is the reinforcement learning. It is a close controlled environment model where in the environment agent take action, and it in the environment the action gives the feedback to the agent as a positive or negative feedback, and from this positive or negative feedback this agent learn what to do, how to do the action correctly with this positive feedback. So this is a closed environment kind of situation where automated car driving or gaming kind of application is it is the application of reinforcement learning. In the high-stake scenario like healthcare, this reinforcement learning does not work very well. Now come to the deep learning convolutional neural network method. Here, the computer vision method is applied to understand the pattern, visual pattern, especially how the spatially means in the image, the intensity value. In CT scan, it may be Hounsfield unit. In MRI, it may be a signal value. In any image, it may be a color or some grayscale value. So all are values. It does not have any meaning. So how it is spatially organized, oriented, that gives the meaning of the image. So that spatial feature, spatial interpretation is done by the convolutional neural network by the convolutional layer and the pooling layer. This whole block diagram is the CNN block diagram that takes layer by layer from higher to more granular level of spatial features it captures. And depending upon that features, it then train the neural network model to have the predicted class. So why it is what it can do? It has many profound application in clinical.
Can you go back to the deep learning and use this images, pooling and all that? It's still not clear.
Sir, this will take maybe 10-15 minute time, and we have the detailed thing in third class.
Okay, all right.
Actually, so it is a whole subject, sir. It takes a full class, but I have summarized for the third class. here I have to, so this convolutional layer, in short, I will tell this convolution layers, these yellow blocks are filters. Filters with different sizes. The more size filter will capture higher level feature. The lower size filters convolutional layer will capture more granular level features. And which features is more important, that will be identified by these pooling layers. So after each type of filtering operation by this convolution layer, pooling layer will identify the important feature from that pool. And step by step, it will grow from the higher to more granular level. I think it makes sense now. And then total features will be going to the dense neural network, and it will then identify the predicted class. It will map towards the prediction. So why it is clinically useful? It do classification, detection, segmentation, and quantification also. How much fibrosis or lesion size is there? So clinically, it can be useful in different sectors that you can understand. Reduce repeated reading task, improve consistent across readers, means inter-reader variability can be reduced because it is machine learning. Every time it will give the same result. And it may detect subtle finding very early in the stage that may be missed by a clinician, by human eye. And it works best in decision support, and it is support to clinical judgment. So for HCC surveillance, CT or MRI image can be used for this. And the clinical value already I have discussed. So next is the deep learning for natural language processing. What it do? What it does is it helps to computers understand and work with human language, such as clinical note, discharge summary, pathology report, radiology report, and referral letters, any kind of text that is used in clinical scenario. So what deep learning improve this is allowing the system to understand the context. The word or combination of word may have different meaning. So the context is the main crux of the document that the model understand. So for example, it can distinguish no evidence of cirrhosis, possible cirrhosis, non-decompensated cirrhosis. So all these phrases contain the same keyword, but they mean very different things. So that context understand these NLP algorithms, deep learning NLP algorithms. So the model is trained on large volume of text. It learns the meaning and context of the word and phrase, means what word is coming after next word, before the word. The all sequence of words is handled by the model, and the context of the meaning is understood by the model. So what exactly?
Make it simple, and then you can correct me, because people need to get engaged. For example, you write a clinical history, a 2-page history. NLP will try and pick it up from reading that. What does it mean in the context when you write probable cirrhosis or definite cirrhosis? Am I right?
Yes.
You can have your case sheet, your handwritten things converted into NLP, natural language processed into definite, probable, and others. Am I right?
Yes.
Okay.
Yes, sir. So it can summarize long record, identify.
It's important to write good history and
Yes.
complete 6-page history examination. That will be converted well.
Yes.
Sorry? Yeah, manual writing, as much as you can write, will be better. If you are converting the known to the NLP, but otherwise in future you can do by directly writing.
So
Problem is, that is how we can take data from our word rounds or OPD sheets.
sir, I can't hear.
OPD sheets we write manually. In Word also put notes by writing, summary also write by this. So I think these are of no use now unless we have the OCR.
So it can be automatized actually. The whole hospital administrative work that handles the text data in written form or in software form, all Everything can be automatized.
There is almost 10 billion word digital library where you write and the machine will automatically pick it up and make a meaning. But we have to write.
Yes. So NLP system can review hepatology clinical notes, admission notes, discharge summary, nursing documentation, everything. And it recognizes phrases. It can recognize phrase like different phrases that we use in the notes. And it can summarize it. It can structureize it to our required report generation kind of, or discharge summary report generation. To whole process can be automatized using this.
I request all the residents not to use their mobiles, but look at the screens and understand this is the way the language will be written at IELTS. You have to understand and see all this is going to be in practice. So please don't look at the phones, but look at the screen.
Now come to generative AI. It has enormous possibility. It can create summary, letters, explanation, or draft document, like asking a capable assistant to read a large amount of material and produce a concise draft or explanation. I think all of us have now experienced generative AI already in some manner. So it is very good to summarize or gather information and give a summarized intellect from that lot of information. So in clinical research, specifically, it can help a lot. It can gather all the research articles. It can gather all the outcome summary and the most important findings from the paper in a second. And it can very fast. It can also give you a scenario, the simulation of clinical scenario, that is very helpful for preparation of examinations when different case is given to you and you have to do the differential diagnostics. So that type of simulation of clinical scenario, it is very good for that. But of course it hallucinates and you have to use it, apply it with very carefully. You have to understand the subject first, of course. You should not learn your subject from generative AI. You can apply generative AI to improve. So, as a whole, it can automatize many process or it can fast many process in our learning or action taken situation. Agentic AI is one step ahead of generative AI. It uses generative AI, machine learning, deep learning, all algorithms, and it can plan and carry out sequence of actions. And here comes the hospital automation, where it can identify a task, it gathers information, it uses the existing rules and checklist, organize the workflow, and then produce output. And it can take action depending upon that output with human confirmation. So, whole lot of work can be sequentially done by the agentic AI, and it is used for automation of any type of action in industry or any in healthcare also. It may be used mostly for hospital administration, not for any clinical intervention or decision making, because it's very high stake sensitive area. It has limitation of having error. Strong governance is needed, means surveillance, and wrong information retrieval can mislead the workflow, and it should not act autonomously in high stakes settings. So we should remember that. So hospital operation is the sector where agentic AI can have application to automatize the process. It may be arranging the roster, day-to-day roster, it may be identifying the availability of bed in the hospital in next 2 days. It can predict different type of this type of scenario it can handle. That need lot of human input. So to summarize, supervised learning is prediction with level. Semi-supervised is learned from the few level, but many are unlabeled cases. Unsupervised is discover hidden subtype in the cluster. Self-supervised is learning general pattern in the unlabeled dataset first. Then reinforcement learning is improving sequential decision over time. Transfer learning is adapt existing model to a related task. CNN is interpret images. NLP is for text. Generative AI and agentic AI for summarizing text and multiple step coordination. So this is the whole landscape and when to use what. So for prediction, diagnostic, severity, risk, outcome, we will do supervised learning. Depending upon our available of dataset or label dataset, we can go for semi-supervised or transfer learning. For image interpretation, we will go to deep learning, computer vision, CNN models. For sequential decision support, reinforcement learning, that is out of our scope for now. Content generation is generative AI. Then pattern discovery within large dataset without any label is unsupervised learning. Text interpretation is for NLP and workflow coordination is agentic AI. This is the whole landscape. Most of the time we will fall within this prediction, supervised, semi-supervised or transfer learning, then image interpretation, then pattern discovery, text interpretation. This left side, this 4 area will be commonly seen in our clinical research. So this is our whole scenario, the spectrum of traditional statistics to machine learning, to deep learning, to agentic generative AI. So we will see, just to summarize what we have learned so far, the core objective, the approach of traditional AI is model driven. We have a predetermined notion of data representation. In machine learning, it is data driven, no assumption is there. Deep learning is about neural network. It representation learning means it identify the pattern in the data set, though any assumption is not predefined. And generative AI, it is context AI, our AI. Whatever the data is, it will handle in that way. So more flexible. Core objective of traditional AI is inference causality relationship making between the outcome and the input parameters. Machine learning takes one step ahead, it prediction, do classification and many more things. Deep learning is complex pattern recognition in the text or image data, and generative AI do content generation. It already understands the pattern, it can generate with the input instruction. Data assumption is in stats, strong assumption is linearly distributed. Machine learning, very fewer assumptions. Deep learning, minimal assumptions is there, and generative AI, no assumptions at all. The clinical applications are in statistical methods, risk score, regression model, trial analysis, all are the clinical application. Then in machine learning, disease prediction, classification, treatment response, assessment, radiomics analysis. CNN deep learning is segmentation of images and moreover ICU prediction, precision medicine. These are deep learning area. And in generative AI, differential diagnostic, treatment planning, scenario simulation, reporting, this type of application is there. Data type is structured for stats and machine learning, and deep learning, structured and unstructured, and generative AI, anything, multimodal. Data volume is small at stats, medium it's ML model, large dataset for DL, and massive dataset for generative AI. Model complexity is low to very high across this spectrum. Interpretability is high to very low, opposite across this spectrum. And validation matrix is used in stats is p-value, confidence interval, hazard ratio. In ML model, accuracy, precision, recall, F1 score, as well as sensitivity, specificity, and area under the curve. In deep learning, the similar way, and in generative AI, this calibration, external validation, clinical utility, the different is the usability aspects of the application. So key takeaway is in medicine, it is a family of method. AI in medicine is a family of method. It is not a single methodology. The right approach depends on the clinical task. High quality data matter more than data type. Machine learning is for structural data, CNN for image, NLP for text. Generative AI helps with drafting and summarization. Agentic AI helps for multi-step workflow support. Local validation and clinical oversight remain essential. And the future is most likely AI with clinician, not AI instead of clinician. Thank you for today.
Very good, Isha. And are there questions or comments or so?
Yes, sir. Yes, ma'am. This is just overall basic idea. Next class we will have machine learning algorithms. I should have mentioned this. Next class we will have machine learning algorithm, and the third class will be deep learning algorithm for CNN mainly, and then transformer, the attention based deep learning. So, and then fourth there will be generative AI. So the three main.
Question papers. So before you start the next class, there will be a test.
So why don't you give this presentation to all of us? We come back prepare. I mean, we read it before we
Yes.
come again.
Circulate
Okay.
to the
That is also done, ma'am, but without telling the things, it may be very difficult. But I can share it. The lectures are already with me. It is already prepared.
Thank you.
So, yes.
Very good, Isha. Thank you very much.
Thank you, sir. Thank you all. Okay. So, this, yes, sure.
Good morning, all. I'm just announcing that on 4th July 2024, we have established the Indo-French virtual node. And it's now on 4th July. This Saturday, we are again celebrating with the scientific bonanza starting from the morning 9 o'clock. So session will start by 9 o'clock. And then 10 o'clock, DBT and DST Secretary Dr. Rajesh Gokhale will address the keynote address. And then again, we will start with the scientific sessions, and inauguration will start by 11:30. I request all of you and the clinicians, researchers, and the students and the faculty to join us for the whole day from the 9 o'clock to the 4 o'clock. Please schedule your work like this that you can maximize the time in the conference. Thank you.